My name is Naval Daver. I'm a faculty in the Department of Leukemia at MD Anderson Cancer Center in Houston, Texas. Today I'll be talking about our trial of azacitidine with nivolumab that we will be presenting at the EHA meeting as an oral presentation this Saturday. So we are one of the first groups to start working on immune checkpoint based treatments in AML and MDS. We presented some of our data at ASH last year. What we have seen in the preclinical studies is that azacitidine, which as we all know is one of the frontline treatments for both high-risk MDS as well as frontline AML, has a number of immunomodulatory activities. So it does some favorable things like increasing MHC1 expression, increasing antigen presentation such as WT1, PREM1, NY-ESO, as well as increasing co-stimulatory modules such as CD40, CD28. But at the same time, it also increases the major immune checkpoints such as PD-1, PD-L1. And we presented data and published this in leukemia 2 years ago. And similar data has actually been seen in solid tumor, in lung cancer, brain tumors that has also been published. So the rational choice was to use the azacitidine that we normally do and try to avoid the negative inhibitory immune activity it has through the upregulation of PD-1, PD-L1 by bringing in a PD-1, PD-L1 inhibitor. And what we saw is in our trial, in AML specifically, we have about 70 relapsed AML patients treated, and we're getting a response rate of about 35 to 40% in the salvage setting. So historically in the salvage setting with AZA alone or DAC alone, we reviewed the data in our institution of about 200 patients, and we saw a response rate of about 15 to 20%. So we're seeing a doubling of response rate. But with immunotherapy, as is well known, the response really is not the key. The critical thing is progression-free survival, overall survival, and tolerability. And we do see that the overall survival, especially in salvage 1, salvage 2 AML, in the relapse setting, is about 10 months. And this is independent of stem cell transplant. Historically, with chemotherapy, with AZA alone, DAC alone, in a similar population, when we compared it, the median survival is about 5 months. So this is very encouraging that we're seeing in elderly patients who have relapsed, we have about a 10-month survival, and at 2 years, about 40% of them are alive. And this is censored for transplant, so this is purely on the treatment regimen. And the tolerability has been overall very manageable. We do see immune toxicities, it's about 20 to 25% of patients, but if recognized early and intervened with steroids, in almost all cases, these were reversible very rapidly within about 48 to 72 hours. But awareness of these toxicities is very important. And furthermore, we did a lot of immune correlative work in collaboration with Dr. Jim Allison and Pam Sharma at MD Anderson, who are our correlative collaborators. And we were able to see that there are immunological factors that can predict for response. So patients who had more CD3 cells in their bone marrow, and specifically more CD8 positive cytotoxic cells in their bone marrow aspirate, were those who had a better chance of achieving a response. In those who had more than 30% CD3 cells, the response rate was almost 70%. So this could be a very easy flow-based or IHC-based marker that could be incorporated into routine AML flows to select patients. We're also seeing some additional markers such as diploid patients who had a 60% response rate and patients with ASXL1 mutations. So now our focus is in the further trials to first move this front line because we think it's encouraging enough, both in AML and MDS. Second, to bring in combinations, because one of the things we saw is that when we treat with AZA and Nivo, we were getting upregulation of CTLA4. So at baseline, most of these people had very low CTLA4, but after PD-1 inhibitor, the major counter-inhibitory pathway, which is CTLA4, became upregulated. So a combination may further improve the response rate from 35–40%. And then third, most importantly, is to identify subsets of patients, either by immunological correlates or using cytogenetics, such as diploid or mutations, so that you could put these people on immune therapies with high confidence of response, and then the others could go to molecular or cytotoxic therapies. So a lot of this is ongoing. There are also randomized studies that are starting up. And so I think in the next 1 or 2 years, there will be a lot of data coming out, both for AML, MDS, with different immune checkpoint combinations. And so far, we're very excited about it.